Hello and welcome. Chances are, if you're watching this video, you're a parent of a child with myopia, or you're a parent who is concerned about keeping your child's vision changes under control. By the way, I'm Dr. Russ Beach. I've been an optometrist now for nearly 20 years, but I'm also a father of two wonderful boys, and one of my sons, my older son, is in fact in myopia management therapy, so this video is important for me on a personal level. Now, in this video, I'm going to give you an overview of what myopia actually is, what it means for your child's long-term health into adulthood, and the main clinically backed treatment options we now have to slow myopia down. My mission is, by the time you watch this video, you're going to feel much more prepared to have an informed conversation with your optometrist about your child's vision. Now, most people know myopia by its everyday name, nearsightedness, and that means your child sees well up close, like reading books, but for things far away, like the board at school or in sports, those things look blurry. But myopia is more than just needing stronger glasses. It's really about how long the eye is. Here's a simple way to picture myopia. Imagine you're using a movie projector and a screen, and you focus the projector so that the picture is nice and crisp on the screen. Now imagine someone quietly comes in and moves that screen 5 feet back. Nothing's wrong with the projector, nothing's wrong with the screen, but the image becomes blurry because that projector is focusing to a point in front of the screen instead of directly on the screen. And that's essentially myopia. The screen is the retina, or the light sensing tissue in the back of the eye. When the eye grows too long from front to back, the images focus in front of the retina instead of on the retina, and that's what causes blurry distance vision in myopia. Now, glasses and standard contact lenses refocus the image onto the retina again so your child can see clearly, but traditional glasses or contact lenses do not change the fact that the eye has become longer, nor do they really address that elongation, but we'll get to that in a second. Now, one question I get asked often is, why does myopia tend to get worse year after year in some kids? Well, children's eyes grow as they develop, of course, but they're not supposed to keep getting longer the same way that the arms and the legs do. In fact, by about age 6, the eye should really be close to its normal adult length, and the growth should slow dramatically by that time. When the eye continues to lengthen after that, that isn't normal growth anymore. That's abnormal axial elongation, and that's what makes prescriptions keep getting worse year after year. Several things influence whether that elongation happens and how quickly it progresses. One is genetics. Myopia runs in families. If one or both parents are myopic, the chances go up that their child will be as well. Another factor is our modern visual lifestyle. Kids today spend many hours a day on close-up tasks, screens, tablets, phones, homework, and less time outside. Research shows that high amounts of near work and limited time outdoors is clearly linked with a higher risk of developing myopia, as well as a faster progression of myopia once it onsets. And as the eye elongates, it isn't just prescriptions that change. That stretching of the eye places more stress on critical structures inside, especially the retina and the optic nerve. And higher levels of myopia are associated with an increased risk of several different eye diseases later in life, including retinal detachments, myopic macular degeneration, as well as glaucoma. These conditions don't usually occur in childhood, but the foundation for that risk is being laid now while the eyes are still growing. So the goal of myopia management is not better glasses. The goal is to slow down how quickly the eye is elongated, so that way your child does not end up with a higher level of myopia and as a result a higher lifetime risk of some of those eye disease complications. The good news is that we now have several research supported treatment options that can slow myopia progression in children. All of them work towards that same goal, slowing down that abnormal elongation of the eye. The first myopia management treatment is orthokeratology, often called Ortho-K or CRT. These are specifically designed hard contact lenses worn only at night. So while your child sleeps, the lenses gently reshape the front surface of the eye, and in the morning these lenses come out and your child can see clearly throughout the day without glasses or contacts. Now, long-term studies show that ortho-K can significantly reduce myopia progression. This is a strong option, especially for kids who are active and don't necessarily want to wear glasses or contact lenses during the day. Now, the second option is MiSight daily contact lenses. MiSight is the only FDA-approved soft contact lens specifically designed to slow myopia progression in children. These are daily disposable lenses worn during the day and thrown out at night. They use a special optical design to create a signal on the retina that slows that excessive elongation. Clinical studies in children have shown much slower progression with MiSight compared to kids wearing non-MiSight contact lenses. Now, the third option is myopia-controlled eyeglass lenses, such as Stellest and similar designs. Stellest became the first FDA-approved spectacle lens in the US for myopia back in the fall of 2025. These lenses feel like regular glasses, but they contain hundreds of tiny treatment zones arranged around a clear central area. Now, these zones use a specific light pattern on the retina, and that signals the eye to stop that abnormal elongation. Clinical studies showed that Stellest can meaningfully slow myopia progression and that axial length growth when worn full time. The fourth option is low-dose atropine eye drops. Now, this is a highly diluted prescription eye drop used once at bedtime. Atropine helps dampen those internal signals that drive that abnormal eye growth, and most studies shows about a 15 to 20% reduction in myopia progression with low-dose atropine. That makes it helpful, especially for milder cases or perhaps as an add-on to those other treatments, but generally low-dose atropine is not as strong of an effect as ortho-K or MiSight or Stellest glasses. So the last question that I get is, when should myopia management be started? Now, we pay close attention to a few different things. One, what is the age when the myopia begins? How much the prescription has changed over the last year or two, and whether one or both parents are myopic. Younger onset, repeated prescription increases, and a strong family history of myopia are all reasons to consider starting sooner rather than later. Myopia management works best when we begin while the eye is still actively elongating and before high levels of myopia have already set in. So let me end with this. Myopia management is about clarity and early action, understanding what's happening inside your child's eyes and knowing that we have effective ways to slow abnormal eye growth. Now, by acting early, we're not just helping them see better today, we're investing in the health of the adult version of your child really decades from now. So if your child's prescription has been changing or you recognize the risk factors that we talked about, ask your optometrist whether myopia management is appropriate for your child. Together, you and your optometrist can choose the best approach that fits your child's needs as well as your family goals. All right, that does it for this brief overview of child myopia progression as well as treatment options. Thanks so much for watching.